Good evening, everyone, and welcome to this wonderful session on the NEET PG mock test discussion. Every day, evening 6 o'clock, we have a live discussion, almost 1.5 hours, discussing these 100 MCQs. And I want all of you to download the Incus app and take the mock test, solve 100 questions. Hardly you will take about half an hour to 45 minutes. All these questions are handpicked, selected, most probable questions which are going to come in the tomorrow's NEET PG. If you religiously follow me, take the test, follow the discussion, decide the topics where you are going wrong, and go back to the HD video library and do the revision of 10-15 topics every day, automatically you will get the top rank in the NEET PG. Good to see SS and many more who are all online. Let's make the great beginning, Doctor. Great. The term dementia precox, it was coined by Kraepelin. So, doctor, in psychiatry, schizophrenia, short topic hai. Only 4 to 5 MCQs come from psychiatry. Still, you should be very sure, schizophrenia. Good to see Ganga, SS and many more who are all online. So it is this great man, Kraepelin, is the one who identified and coined the term dementia precox. Today, the same dementia precox is being called as NEET PG preparation. No. It's called schizophrenia. Now, emotion is controlled by, why do we cry? All emotions are controlled by your frontal lobe. Frontal lobe is for abstract thinking. Social inhibitions are because of the frontal lobe. So those people whose frontal lobe is very prominent, they are good thinkers. Now, memory is something you should know that limbic system is important. The frontal lobes also play a role to retain long-term memories which are not task-based. That's a point you need to appreciate. So what are the various tests that test the frontal lobe function, doctor? Finger tapping, Wisconsin card sorting task, and how good is the verbal fluency, figural fluency. They're all the tests for the frontal lobe function is what you need to remember. In the withdrawal, you don't need to treat in case of LSD. Idiot savants. Once more, with regard to the previous question, I want to tell you, doctor, substance abuse is a very high yield topic, so many times repeatedly asked. Cannabis, amphetamine, LSD, what will be their symptoms? Will they have withdrawal or not? What is hashish? What is bhang? All these things. Examiner pakad ke puchega. So you have to be very sure. Once more, Incus 2000 HD videos. If you go to forensic medicine or in psychiatry, you have all these substance abuse related videos, which you can do the revision. Idiot savants. who have a prodigious rote memory. Some people get 95%, 98%, 99% in theory exam. But you challenge them in a multiple choice question exam, they are completely clean board. They also have very good calculating ability. From the front, from the back, from the back, from the front also they can tell the numbers in the mind. They often have autistic disorder. So Savant syndrome is a condition where the person demonstrates a prodigious capability, more than excess, when it comes to calculation, art, memory, musical ability, etc., etc. Now, everything, anything about lithium you should answer, doctor. Once more. Each of this question I am telling you, doctor, these are all hand-picked questions. Most probable questions going to come in tomorrow's NEET PG, FMGE, INI CET. There are only 3 exams now. Yeah. So you should remember, after 5 days of constant dosing, serum lithium level should be checked. So what is the dosage? Therapeutic dosage. 0.8 to a maximum of 1.5 millimoles per liter. And after you've given the lithium, you want to know whether it is adequate or not, 4 to 7 days. And after that, at least once a week, until the dosage remained constant for 4 weeks. You have to do the therapeutic monitoring, is what you need to remember. Scarski's rings, you can see on the barium swallow. The tissue harmonic imaging. Very good. Moin Lala, बहुत अच्छा आंसर दे रहे हैं. So while you are listening to the class, you keep mentioning some good points that come to your mind. That's how this revision session will be very, very interesting, doctor. Tissue harmonic imaging involves use of the sound waves. And how does the extradural hemorrhage look like in CT? It is a biconvex, is what you have to remember. If you want to detect intracranial hemorrhage, always it is the CT. Whenever a patient of stroke comes now, first get a non-contrast CT is considered to be the investigation of choice in case of stroke. Mainly if you want to rule out whether it is a ischemic or a hemorrhagic stroke, you require the non-contrast CT. Once more, this is a sylvian fissure. The blood is getting accumulated in the sylvian fissure and in the cisternal spaces. That is the reason it is a case of subarachnoid hemorrhage, is what you should remember. The raised ICT, what does it lead on the plain radiograph, doctor? Typically, there is a sutural diastasis, cellular erosion, increased convolutional markings. They are all the classical features. You see, there are increased convolutional markings. Increased convolutional markings is a sign of raised intracranial tension, is what you need to remember. Then this is also called copper beaten skull, is the name given for it. Copper beaten skull. One of the favorite questions of the examiner. Barrett's esophagus. The classic Barrett is 3 centimeters or more of columnar epithelium. Short segment Barrett is less than 3 centimeters. And interstitial metaplasia is definitely a risk factor. Who said it is not a risk factor? So this is how endoscopically a Barrett's esophagus typically looks like, which you need to appreciate. And this is the intestinal metaplasia. Intestinal metaplasia of Barrett. Would you not recognize this image-based question when they give it tomorrow's exam? You should know how to identify. Intubated patients with a severe cord injury, even in an intubated patient, what is a strong predictor? This is the typical Bailey and Love surgery-based MCQ. I don't know, modern students, do they know or did they ever hear about Bailey and Love, Davidson? They are evergreen treatises of undergraduates. Priapism is a strong predictor of a severe injury. There is a cord injury, even in the intubated patients, is what you need to remember. Very good. Moyen-Larsen sutural diastasis is the first marker of the ICT increase on X-ray. Very good. Very good. So the whole purpose of our daily live online communion is to bring exchange of points, exchange of notes. So if you download the Incus, it is like a community. To any other student, you can be able to instantly chat with them, etc., etc. Now, doctor, chain of lakes appearance. Where do you see chain of lakes appearance? In chronic pancreatitis. There is clubbing on the side branches. This is the main pancreatic branch. So chain of lake appearance in chronic pancreatitis. So you can see the clubbing and dilatation of the side branches. Here is the stone. This is the main pancreatic duct. And there's an increased tortuosity of the main duct. All the classical features. What is the definition of oliguria? Typically, less than 300 ml of the urine excreted by the patients. So that is 17 to 21 ml per hour. So generally it is anything less than 400 ml, you call it as the oliguria. In case of infants, 1 ml per kg per hour in infants, and in children less than 0.5 ml per kg per hour. And in the case of the adults, 17 to 21 ml per hour. That is the clinical definition of oliguria. One of the favorite ward round question asked in the actual entrance. Would scan to see the collecting system dilatation. It is a technetium DTPA scan. So you should know, doctor, what are the various radiopharmaceutical agents for each of these purposes. For glomerular filtration, it is the chromium 51 EDTA and technetium DTPA. For tubular secretion, we use MAC3 and technetium EC. Tubular retention, DMSA, and also for the cortical imaging. Any distortion in the cortical structure, you can make it up. So for the collecting system dilatation, the best test is 99M technetium DTPA is what you need to remember. Retrograde cystograph showing a thimble bladder. Where do you see? Thimble means exceedingly contracted bladder. Tuberculous cystitis. So this is how a retrograde cystograph typically shows exceedingly contracted thimble bladder. Thimble bladder. Once there is a tuberculous cystitis. All the patients with proven rectal cancer require staging by liver, chest imaging, by CT along with the local PET scan is what you need to remember. Very good. Moin Lala rightly tells DTPA does not require tubular secretion or absorption. So it is used in GFR measurement only. Very good. Very good. So this is a typical Bailey and Love based MCQ once more. All patients with proven rectal cancer, you can see when PET scan is being done, you are able to see intense glucose metabolism as well as a detailed anatomical view. Now, the valves of Houston is a favorite question of the examiner. The valves will disappear after you surgically mobilize the rectum. So if you look at the valves, there is a superior rectal valve, inferior rectal valve onto left side. On the right side, what do you have? Middle rectal valve. So this is the dentate line. This is the anal verge, and the distance will be around 1 to 1.5 centimeters is what I want to underscore to all of you. So if you look at the non-mobilized rectum, it has 3 curves, lateral curves. So this is one lateral curve, this is one lateral curve, and this is one lateral curve. Intraluminally, that will create a fold, which is called Houston's valve. Of all these valves, the middle valve is most consistent in location, middle valve. And it is also called Kohlrausch valve, Kohlrausch plica. And it is this middle valve from where the anterior peritoneal reflection typically happens. And these valves do not contain all the muscle wall layers, is what you need to remember. Now, PUD orange, cutaneous lymphatic edema, is responsible for PUD orange. Gallbladder cancer stage 1A, what is your treatment? Basically follow up. So what is the principle? If the tumor is carcinoma in situ or it is only invading the lamina propria, which is T1A, and the margins of resection are negative, then only post-operative observation khali kare to kafi hai. That is the protocol which you need to remember. Very good to see Srijana Sriram. Excellent, doctor. If the tumor is T1B or greater, or the margins are resection are positive, if no metastatic disease is present on evaluation, then a second surgical resection is required. And whenever you do second surgical resection, compulsory you should include partial hepatic resection and regional lymphadenectomy. In the case of the gallbladder cancer, the important surgical management principles which you need to remember. Now, for the treatment of pneumoperitoneum, because of the early and large colonoscopic perforation in a young patient, how do you treat? So whenever rupture is suspected, a plain radiograph in the erect and lateral decubitus position will show the free air. And in all these cases, exploration should be done, and you need to do a simple closure of the perforation. That is all that is required. But if the mesentery is lacerated, if the bowel is not viable, then only resection will be necessary. Now coming to the large intestine, if it is a small clean tear, you can close it primarily. If there is a large tear with the damage of the surrounding structures and adjacent mesentery, then you need to do the resection, exteriorization. That is what you have to basically do. Oshner-Sherden's regime, it is used for the appendicular mass. So Oshner-Sherden क्या होता है? Expectant management is being given to the patient who is having appendix mass. Admit the patient, administer fluids, give potassium, give vitamin C and B, give antibiotics, give analgesics, pass nasogastric tube, monitor the urine output, monitor the pulse hourly, and measure the mass, the diameter of the abdominal mass every 12 hours. Oshner-Sherden's regime is what you need to remember. Now, doctor, the commonest clinical pattern of basal cell carcinoma is nodular. Nodular is the most common pattern which you need to remember. Where are pressure source? Most of the times it is the ischium. Ischium where you find the pressure source. Stenson's duct is the duct of the parotid gland. Parotid gland is the Stenson's duct is what you should remember. Now, pheochromocytoma, adrenal medullary disease. Mallory-Weiss syndrome, it is a longitudinal tear of the mucosa at the gastroesophageal junction. The lower one-third of the rectum is separated from the coccyx and the sacral vertebra. What is that fascia? It is called Valday's fascia. So, you can very clearly see the sacrum and the rectum. So it is the Valday's fascia. Where is it located? You need to be very sure about it. And this is the levator muscle. The levator muscle and a coccygeal ligament. So all these structures you have to be very sure, doctor. So what is the gold standard if you want to diagnose common bile duct stone? Endoscopic cholangiography is the gold standard. So this is how you can identify the presence of the CVD stones. Endoscopic retrograde cholangiopancreaticography is considered to be the gold standard. Nothing else is considered to be gold standard. Be very sure. Lawrence classification of carcinoma stomach. So basically, there are only two types, not three types. One is called intestinal type, doctor. You have to be very sure. Lawrence classification. Intestinal type होता है differentiated, distal stomach, endemic areas, older people, males, mainly inflammatory and environmental factors are the risk factors. Whereas diffuse type, less differentiated, signet ring type, mucin producing, extensive submucosal distal spread tend to be more probable, more common in the women, and genetics is the underlying etiology if it is the diffuse type. So once more, doctor, जरा ये table को बट्टी मार लेना, definitely आने वाला good, high probability topic. I don't say sure shot topic, but high probability. Because gastric cancer is very common and you should know everything, anything about it. So it is the microsatellite instability, APC gene mutation for the intestinal type. Whereas decreased E-cadherin is implicated in diffuse type, is what you should remember. Excision of the prolapsed rectum and associated sigmoid colon from below and constructing a coloanal anastomosis. भैया इसको क्या बोलते हैं? Altimier's procedure. So whenever prolapse is there, the rectum and the associated sigmoid colon is being resected, and you will be forming coloanal anastomosis, which is called as Altimier's procedure, is what you need to basically remember. So perineal procedures may Thier's widening, Delorme's mucosal sleeve resection, Altimier's perineal rectosigmoidectomy. Of all this, the most common is Delorme. Altimier is an alternative perineal procedure. Now, doctor, 1 centimeter insulinoma in the distal part of the body of the pancreas. How do you want to treat? Enucleation is considered to be the management of choice, is what you need to remember. 6-7-year-old with obstructive jaundice, ultrasound shows gallbladder distended, bile duct dilated, and also there is a mass in the head of the pancreas. What is the likely possibility? How do you evaluate the resectability of this tumor? What is the best imaging technique and trick? It is the CT scan, which shows the size of the tumor, infiltration into adjacent structures, etc. The commonest type of mesenteric cyst होता है chylolymphatic cyst. So mesenteric cyst can be like this, which is called chylolymphatic, or it may be rising from the wall of the gut, which is called enterogenous cyst. Between the two, chylolymphatic or congenitally sequestered lymphatic tissue, and these are most common type. So now, doctor, examiner 3-4 points he will ask about each of these types of mesenteric cysts. Enterogenous cyst, it is a failure of the leaves of mesentery to fuse, and all that sequestered intestinal epithelium is the one which you will basically see. And it is thick wall lined by mucosal membrane. Content is mucinous, which shares blood supply with the adjacent intestine. The blood supply is shared between the two. Treatment is resection and anastomosis. Chylolymphatic जो होता है most common type. It is the congenitally misplaced lymphatic tissue. Content is chyle unilocular. It has the independent blood supply, and treatment is mainly enucleation. So this is a favorite MCQ of the examiner, doctor. Treatment of enterogenous cyst versus chylolymphatic. Enterogenous cyst, you will remember, treatment is resection and anastomosis. Because it is closely budding with the gut. So unless you resect the part of the gut which is fused, how can you manage? And do the anastomosis of the remaining part. This has no relation with the gut. So that is the reason this can be enucleated is what I want to underscore to all of you. And one more important principle, physical examination में क्या है? If you take this line between the right superior iliac spine to the left hypochondriac area, if you draw this line, the cyst will move perpendicular to that, not in the direction of the line. That's how the swelling is identified as the chylolymphatic cyst. Hip spring, there will be a ganglionic area. If you do the suction biopsy, which is the confirmatory test. A 68-year-old woman with aortic stenosis with diabetes, maroon colored bleeding per rectum. Very important. What is the possibility? Vascular malformations. Angiodysplasias, maroon colored blood. What are the complications of the diverticular disease, doctor? It can lead to fistula, intestinal obstruction, pericolic abscess, very unlikely to become a carcinoma. Ulcerative colitis affecting only the rectosigmoid, sparing the descending right and transverse colon. The principle is, if the disease is limited to only the rectum, the cancer is less common. Is what you need to remember. So the commonest site of gallstone ileus, distal ileal area, that is the ileocecal junction. Commonest type of intussusception is ileocolic. Commonest cause of the dystrophy is fracture humerus. Occult fracture of the femur heto. Occult fracture of the femur. How do you identify, doctor? MRI is considered to be the investigation of choice. McMurray's test on the knee, mainly to look for the meniscal integrity. So you will be doing a circumduction. So to evaluate the tears of the meniscus of the knee. Diaphyseal achalasia, etiologically is congenital. So hereditary multiple exhaustosis. It is also called diaphyseal achalasia. Is the autosomal dominant. Multiple osteochondromas will be forming. So this is how the multiple exhaustosis will be developing, and osteochondromas, multiple osteochondromas will be developing. The most common complication of supracondylar fracture होता है cubitus varus, gunstock deformity. Brody's abscess is chronic osteomyelitis. Congenital torticollis में it is the sternocleidomastoid which is contracted. So sternocleidomastoid is contracted. Chopper's fracture is the fracture of the radial styloid. Tomorrow's NEET PG examiner is going to give you one of the acronymously named fracture. Spondylolisthesis. You will be doing a lateral X-ray, MRI, CT, etc., etc. So this is how the slipping of one vertebra over that of the other vertebra, you can be able to identify spondylolisthesis. What is this called? It is called as Scottish Terrier sign. Scottish Terrier sign is what you need to remember. Mallet finger. It is the distal end of the extensor tendon. Disruption will lead to mallet finger. LASIK, you use the excimer laser. Kaiser-Finks, typically in Wilson. Berlin sedema, blunt trauma to the eye. Specular microscopy for corneal endothelium. Jonular cataract can be congenital or developmental. So the commonest type of congenital cataract होता है jonular cataract, जिसका दूसरा नाम है lamellar cataract, is what you need to remember. Snow banking is a typical feature of intermediate uveitis. Intermediate uveitis. What is uveal tract? Iris, then ciliary body, and choroid. Choroid is called posterior uvea, iris is called anterior uvea, ciliary body is called intermediate uvea. So, pars planitis is a subset of intermediate uveitis where white exudates or the pars plana and aggregates of inflammatory cells in the vitreous, which is called snowballs. So snow banking is the feature which you see in case of intermediate uveitis, is what I want to underscore to all of you. Hordeolum internum is a suppuration that occurs into the meibomian gland, is what you need to remember. Retina embryologically comes from neural ectoderm. Forced fugue spots. So the pigment epithelium proliferation typically is called forced fugue spots, which is seen in degenerative myopia. When the myopia is very severe, there will be peripapillary atrophy, tilted disc. Fundus looks tessellated thyroid fundus, it is called as, and luckier cracks, and multiple areas of pigment epithelium and choriocapillary atrophy involving macular area. And this pigment epithelium proliferation is called Foster Fuchs spots. In case of degenerative myopia is what you should remember. Chronic acquired dacryocystitis. How do you want to treat it? Dacryocystorhinostomy. So there is a new opening which is created above the level of the block. Above the level of the block to let the tears pass. Anode cells, partial group of ethmoid cells. So the sphenoethmoidal A cells are called anode cells. They are the ethmoidal A cells that lies posterior to the sphenoid sinus, but why are we worried about them? Because they have very close relation to optic nerve, internal carotid artery. So that is the reason you should identify these anode cells. Whenever you are trying to enter into sphenoid sinus endoscopically, there is a chance of damaging this optic nerve. A caustic neuroma arises from inferior vestibular nerve, the acoustic neuroma. So there are two different answers. Logan Turner, one of the great book on ENT, says it is superior vestibular nerve. The recent literature says inferior vestibular, but inferior vestibular is a better answer. Paragangliomas, from where do they arise, doc? So you can see the paraganglioma. So they arise from carotid bifurcation or jugular foramen, as what you can see here. Jugular foramen. Paragangliomas can arise. And the promontory of the middle ear. Now, unilateral vocal cord paralysis, how do you treat? Ishiki type 1 thyroplasty. Abba, this is one topic I used to hate to prepare in the NEET PG, in the PG medical preparation days. Tomorrow you won't become ENT surgeon. You may become dermatologist. Why do you need to know about Ishiki, Pishiki and all these things? Still examiner will ask you. As a filter lagayega examiner. But let me tell you once more. NEET PG mein, kal ke exam mein 7 to 8 MCQs are going to come from ENT. In that, vocal cord paralysis is the favorite topic, doctor. What will be the position in different types of vocal cord paralysis, blah, blah, blah. The examiner will play with your piece. Please go back to the Incus app. Incus app and try to do the quick revision. There are 2000 HD videos which are available for you to do the revision. So, type 1, you do medialization, type 2, lateralization, type 3, shortening and relaxation for lower pitch. Type 4 is lengthening the tension to raise the pitch. So you should know the 4 types. What do you do? What is their purpose? Once more, I leave the literature for you, doctor. All this PowerPoint is made available in the Incus app. What are the indications? What is the principle? Everything, I leave the literature for you. Rhinitis medicamentosa, xylometazoline. Pre-epiglottic space is also called the space of Boyer. So here you find a lot of fatty tissue, doctor, pre-epiglottic area. In modified radical neck dissection type 1, which structure is preserved? So basically there are three structures: spinal accessory nerve, internal jugular vein, and sternocleidomastoid duct. So the original radical neck dissection has been modified so that some of these structures are all preserved. So if the SAN is only preserved, then you call type 1. SAN and IJV, type 2. SAN, IJV, sternocleidomastoid, type 3. That's what you should remember. Cochlea is fully developed by what age? By about 12 weeks of embryonic life. External auditory canal 24 mm, outer is 1/3 cartilage and inner 2/3 is bony. Prusac space. Where is it there? It is there in the epitympanum, is what you need to remember. So, posterior to the pars flaccida, which is the part of the tympanic membrane, the area is called epitympanum. So, this is the tympanic membrane, doctor. Pars flaccida के पीछे होता है this Prusac space. Why do you want to remember it? Because retraction pockets, cholesteatoma, they're all very common in Prusac space. So what are the boundaries of the Prusac space? Pars flaccida, laterally, neck of malleus, the malleus neck, medially. So typically this part is called Prusac space. Superiorly lateral malleolar fold and inferiorly lateral process of the malleus. So that is how the Prusac space is located. So doctor, we will take a quick 5 minutes break. Daily 6 p.m. to 7:30 p.m. 100 MCQs, 40 grand tests. This is the discussion time. 40 grand tests, March 5th to April 15th. Please tell all your friends, Dr. Murali Bharadwaz is at your service every day. So download Incus app. Take the test every day. I am writing a prescription for that is the prescription to become the topper in the NEET PG. Just give me 5 minutes time. We will restart and finish the remaining 30 questions. So welcome back to the session, Doctor. Monochorionic monoamniotic twins occur when, if the division occurs when? If the division occurs more than 8 days. So you should remember one important thing. I'm telling you once more. Yesterday भी मैंने बोला, आज भी बोल रहा हूँ. Sure short topic in obstetrics होता है twins, multiple pregnancy. Everything, anything about the complications, type of twinning, everything you should be ready. So if the separation of a single ovum occur at 8 to 13 days, by this time the trophoblast is already formed. It will yield a single placenta. And the fetuses will share a single chorionic sac, single yolk sac, single amniotic fluid. And they are often identical twins and of course of the same gender. So that is the story of monochorionic monoamniotic twinning. Typically is seen if the division occurs more than 8 days. A live attenuated vaccine is contraindicated. It is contraindicated. So HPV, mumps, measles, whereas rabies is a killed. So that's the reason it is not contraindicated is what you should remember. In the pregnancy, the secretion of the colostrum, it is at around 12 weeks. What is the root value of the pudendal nerve, doctor? It is S2, S3, S4 is the root value. So from S2, S3, S4, the pudendal nerve will be arising, which is not a feature of the cervical changes near term. So the breakdown of the collagen, decrease in dermaton, sulfate, increase in hyaluronic acid, they are all the important changes that occur during in the cervix. And this is called cervical ripening. Who brings about this ripening? It is a prostaglandin E2 which plays a very important role. For 325 milligram of ferrous sulfate, kitna elemental iron hoga? 60 to 65 milligrams. Variable decelerations, cord compression. Then early deceleration, head compression. Late deceleration, very ominous. They indicate fetal hypoxia is what I want to underscore to all of you. So how much folate is recommended, doctor? 400 micrograms, 400 to 800 micrograms per day. Who started this concept of alert line, action line? It is the Philpott. Philpott and Castle. Philpott and Castle. In 1972, they introduced this important thing in the Friedman's partogram called alert line. It is the mean rate of the slowest progression of the labor is called alert line. And the action line is the time where appropriate action should be taken. And always the normal labor is plotted left to the alert line. Philpott and Castle. Placenta is formed by the fusion of chorion frondosum with the decidua basalis. So you should know all this important part of the structure, doctor. So you have the decidua parietalis here. This is the chorionic cavity. The decidua capsularis, then chorion livae, the uterine cavity, This is the yolk sac, the amniotic cavity, and this is the chorion frondosum, and this is the decidua basalis. So how is the placenta basically formed? With the chorion frondosum and the decidua basalis, their fusion will lead to the formation of this placenta, is what you have to emphatically remember. So what are the two substances which are needed for the developing fetus to grow? Male genitalia. पहला तो टेस्टोस्टेरोन होना है, अगर वो नहीं है तो अनडिसेंडेड टेस्टिस बन जाएगा, जैसे एंड्रोजन इनसेंसिटिविटी सिंड्रोम में. In androgen insensitivity syndrome, what happens? Testis remains undescended and remain in the inguinal canal because the testosterone is unable to act on the receptors in androgen insensitivity syndrome. So testosterone rehna hai, Mullerian inhibitory factor should be there, then only Mullerian things will be suppressed. Mullerian gives rise to female genitalia. Female. Wolffian is to the male, as all of you know very well. Which is called the living ligature, Dr. Myometrium. MTP will allow you only before 20 weeks. Which drug you should not give before delivery of baby duck? Methyl ergometrin is used just after the baby is born to help the delivery of the placenta. So what are the complications of the fibroid? Fibroid can become red degenerated, obstructed labor, PPH. Anything it can lead to. Billings method of contraception. It makes consistency of the cervical mucus, will help you to know, the woman to know what is the ovulatory period. Mittelschmerz pain is a sign of ovulation. Ovulation pain. With regard to the ovarian cancer, ascites, hydrothorax and malignant ovarian tumor together is called Meeks syndrome. Meeks syndrome. The most common type of the ovarian cancer is epithelial ovarian cancer. And the most common symptom of the ovarian cancer is bloating, abdominal pain, trouble eating, feeling full quickly, urinary urgency and frequency. They are all the most common symptoms. Mullerian duct fusion में अगर गड़बड़ हो गया तो then that lead to formation of uterus didelphys. So tomorrow this becomes a image-based MCQ for you, doctor. Be very sure to recognize. So these are the uterine horns, double cervix, fallopian tube. So uterus didelphys, you should recognize. Schiller dual bodies, endodermal sinus tumor, you have Schiller dual bodies, And this is one more example of Schiller dual bodies. When do you want to do endometrial sampling, biopsy in a postmenopausal bleeding? If the endometrial thickness on ultrasound is more than 5 millimeters, you should do the endometrial sampling. Large amount of alkaline phosphatase. When do you see? Whenever it is the proliferative phase, before ovulation, when under the influence of estrogen, there is a proliferation happening, that is the time. Levonorgestrel releasing intrauterine system. It can be used as a hormone replacement therapy. Similarly, levonorgestrel being a progesterone will lead to the atrophy of the endometrium. Irregular uterine bleeding can be a problem with levonorgestrel releasing system, but generally it will decrease the incidence of menorrhagia, not increase. Myxoma peritoneum, where do you see? Whenever there is a rupture of the ovarian cyst, mucinous cystadyloma. Adenomyosis, what is the most common symptom? It is the menorrhagia, because the increased uterine size and endometrial surface, there is menorrhagia. Subnuclear vacuolation. Subnuclear vacuolation. Typically, it occurs in the secretory phase under the influence of progesterone. So this is a 16-day endometrium showing subnuclear vacuolation. So post-ovulatory one. So you can once more see, these are all the subnuclear vacuoles. Subnuclear vacuoles. This is the stroma, this is the surface epithelium. These are the nuclei, subnuclear vacuolation, which is suggestive of the secretory phase. Cervical cancer expands and compresses the ureter, leading to uremia, chronic renal failure, which is the most common cause of death. Lower vagina drains into superficial inguinal lymph nodes. So upper 1/3 follows lymphatic drainage of the cervix. The lower 1/3 drains to the inguinal lymph nodes. And the middle 1/3 of the vagina drains both in the upper direction and also in the lower direction. The middle 1/3. Middle 1/3 of the vagina. So if you look at the uterus, cervix, what is the lymphatic drainage? This is very important. Uterus has upper segment, middle segment, lower segment, doctor. Upper segment, superficial inguinal and aortic lymph node. Middle, external iliac lymph node. Lower interiliac and external iliac and sacral, epigastric and superficial inguinal lymph node. So the mnemonic is USA, me, lies. U, upper, superficial, inguinal and aortic, USA. Me, middle, external iliac. Lies, lower is interiliac, external iliac, sacral. So this is one of the favorite MCQ which you need to remember. The fundus, the body, the cervix. In the cervix, the lateral part, the posterior part, the posterolateral part. What is the lymphatic drainage is a favorite question. So this is acute Bartholinitis. So now the question comes. What is it because of? Commonly it is the gonococcal infection. CIN, Carcinoma Institute of the cervix. In the lower socioeconomic groups, multiparity, not nulliparity, multiple sexual partners, onset of the coitus at an early stage, they're all the important risk factors. So, multiparity is believed to be the risk factor for the cervical cancer is what you need to basically remember. So, doctor, I wish you all a great preparation time every day with Dr. Murali Bharadwaz. Morning, download Incus app, take a daily mock test of 100 MCQs. Evening at 6 o'clock, join for the discussion. Pick up 10 to 15 topics. Every time I tell the same. Small goals every day. 10, 15 topics every day. 30 days, you travel with me. You are going to be the winner. Good night and see you all tomorrow at evening 6 o'clock. Good night.